Hello, good morning, doctors. This is again Dr. Sasi. Welcome to the game changer session of this pathology part. So, without wasting time, let us move on to the topics. First, you're able to see the first topic we're going to discuss it is what it is the cell injury. You know, when there is a normal cell, like it will perform its normal function. But when a cell undergoes ischemia or when a cell undergoes a stress, it leads to this cell injury. For example, there is a normal cell. Because of a thrombus, the blood flow is decreased blood flow, and because of this decreased blood flow, the cell blood flow will be decreased. And because of this, ATP generation will be decreased, and if there is decreased ATP generation, and we know there is a pump which we studied yesterday, which is a primary active transporter. Which of the following pump is an example of primary active transporter? Yeah, guys, that is what it is, the sodium potassium ATPase pump. It is a sodium potassium ATPase pump, and if there is any failure of this pump, because there is no blood supply and there is no oxygen, because if there is no oxygen there will be no production of ATP, and if nothing happens, then the cell will undergo injury or the cell will be injured because of this ischemic one. And after this, if you see, because there is no sodium potassium ATPase pump, the sodium will start collecting inside. When the sodium start collecting inside, then you know this sodium will absorb more water. So when the sodium will staying inside the cell, it will absorb more water. When it absorbs more water, then we'll able to see this first light microscopic changes in cell injury. The first light microscopic changes in cell injury, it is what it is, a cellular swelling. So cellular swelling, it is the first light microscopic changes. Okay, and this is known as the hydropic change. And once there is a cellular swelling and this fluids, it will start accumulating into the other organs as well. For example, the mitochondria will get swelled, and there will be this detachment of these ribosomes. Remember, there will be detachment of these ribosomes in a case of reversible cell injury. First, there will be a normal cell, followed by this injury, it will go for this reversible cell injury, because if we remove the stress, after a certain point, the cell will perform its normal function. That is known as reversible cell injury. But there will be a certain point at which this normal cell cannot do its function again. That is known as irreversible cell injury. We studied yesterday, right? There is this action potential in physiology in which there is a threshold level. Once you reach the threshold level, then the action potential starts generating. Okay, the action potential generates after a threshold level. Likewise here, there will be a time till which it is known as reversible, and after which the cell will become irreversibly injured. Okay, that is the concept here. And if you move on with this, and what are the changes? I told one is this cellular swelling, next one this mitochondrial swelling, and you will be able to see this type of membrane swelling. It is known as membrane blubbing. So membrane blubbing, cellular swelling, and mitochondrial swelling, and along with this ribosomes get detached. It is known as ribosomal detachment. Okay, it is known as ribosomal detachment, right? And these are the few changes which you see in a case of reversible cell injury. Whereas once these things get passed, if the stress is not yet relieved, then it will go to this next process which is known as irreversible cell injury. In a case of irreversible cell injury, it leads to this lysis of this membrane. So the membrane will be damaged in a case of irreversible cell injury. So in a case of irreversible cell injury, membrane will be damaged. So we know if the membrane is got damaged, then it leads to this leakage of this content to the outside. Okay, leakage of this content to the outside. Just remember this. And why it is irreversible? Because if there is just cytoplasmic changes and other organelle changes, it can be reversible. But if the changes started occurring into the nucleus, then it becomes irreversible. So initially, our chromosomes will be like this. It will be like a woolen ball. You know, right? Woolen ball. So it will be like a woolen ball. But once there is injury started occurring, it will just initially it will start to clump together. So in a case of reversible cell injury, there will be this clumping of this chromatin. So reversible, there will be a cellular swelling, mitochondrial swelling, ribosomal detachment, and there will be a clumping of this chromatin in the nucleus. Okay, these are this reversible one. Whereas in a case of irreversible cell injury, what will happen? It will leads to this deposition of this material into the cytoplasm. There will be deposition of the material, first one. Second one, the membrane will be damaged. There will be lysis of this membrane. And third one, what will happen is nuclear changes. What are the nuclear changes? As I told you, this is how this normal nucleus looks like. It is like a woolen ball. You know, right? Woolen ball, there will be this much spacious and it will be very compactful. Whereas in the case of irreversible cell injury, this compacted one become clumped. Means it is like the crushing of your tissues. Like it will be compact. When you crush, it will become very small. So this is known as pycnosis. This is known as pycnosis. Here you will be able to see some spaces, but here there is no spaces. Then it is known as pycnosis. And once there is a clumping, then the cell undergo next changes, which is the irreversible one. Then this nucleus should be removed, because in this cell there will be a presence of this structure which is known as lysosomes and lysosomal enzymes. And this lysosomes and lysosomal enzymes, what they will do, they will start digesting the cell wall and into the nucleus. When they go into the nucleus, they will break them into small parts. For example, take up your journey of your FMGE, or take up the journey of any competitive examination. The information everywhere, it is widespread. If you open YouTube, if you open any book, there is already enough amount of information. But if you see, they are very much spreaded. In the case of inflammation, what it will do, it will clump. Means you need information which is required to pass a specific examination, that is FMGE. So for passing this FMGE, you need to know what are the PYQ questions, what are the PYQ topics, what are the must-know topics, and you should have a strong base notes. So if you have all this content, then everything will be together. So if you have this content in a simple set, then what you should do is you need to split them up. What is the weightage topics? What is the notes tells you how to solve this question? So you need to decode them. That's why if you able to see here, you will separate them into small pieces. Once you separate them into small pieces, then it will be very easy for you to lyse the information or to understand the information. So initially there will be this normal nucleus, followed by this clumping, which is known as pycnosis, followed by this small breakdown, it is known as karyoresis, and followed by this there will be this lysis of this complete chromatome material, it is known as karyolysis. Okay, that's all. So this is the things which you see in a case of normal irreversible cell injury. And in a case of irreversible cell injury, there are different types. There might be a programmed one, there might be a non-programmed cell death. In a case of programmed cell death, we'll call them as caspase dependent programmed cell death. And this type of caspase dependent programmed cell death, what it is known as? Hey guys, it is known as apoptosis. And we know if this apoptosis occurring in liver, then this liver cells, it will become small because of after its death, and it will become pink in color. So what is the name of this body? You will see in a case of liver, it is the Councilman bodies. It is known as Councilman bodies, which is seen especially in a case of hepatitis in the liver. Okay, hepatitis in the liver. Sorry. Then, in a case of irreversible cell injury, I told you this leads to this accumulation of few particles. If this calcium, if it is getting accumulated into the mitochondrial content, it will start accumulating into this circular fashion. Can anyone tell me what is the name of this fashion in which this circular deposition of this debris and the calcium material in the mitochondria? It is what? It is the myelin figures. It is the myelin figures. Remember, it is known as myelin figures, which is seen in a case of reversible and irreversible cell injuries. And mostly it is more prevalent in irreversible cell injuries. And after this cell is being dead, or this, there will be debris will be there, right? So that this debris will start accumulating. So we know when we see a packet before packing or before eating something, it will be very nice. But when you throw, it won't having a proper shape. So after cell injury, there will be this deposition of this material which won't have any proper shape. So we'll call them as dense amorphous without morphology, dense amorphous densities. And how will you differentiate this amorphous densities? In a case of reversible cell injury. In a case of reversible cell injury, this amorphous density, it will be less. Whereas in a case of irreversible cell injury, we call them as, how will call them? We'll call them as this thing which is known as what? Flocculent amorphous densities. Amorphous densities. See, this both of them, they are this electron microscopic image in the case of inflammation part, and in inflammation you will able to see this one. This is this irreversible and reversible one. In the case of reversible there will be this less densities, whereas in the case of irreversible there will be more amorphous densities. Fine, that will discuss on long run. Don't worry. So these are the parts are the cellular changes you need to remember for this first part, which is this reversible and irreversible cell injuries. Next, we'll move on to the next part, in which we'll learn about this apoptotic and anti-apoptotic genes. So most of these pathological genes and the pathological parts, it is most of kind of remembering. So try to make some mnemonics or stories. I will help you out with some of these mnemonics. ठीक है, मुझे जो पता है उसके हिसाब से I will tell you few mnemonics. आप उसको यूज करके आप याद रख सकते हो. You can keep these things with few mnemonics, then it will be easy and cakewalk for you. So how I used to remember is, if you see this one is anti, okay, if there is someone anti to you or if someone is against to you, what you will do? You will clear them. You will clear them. So remember, this anti everyone will be having this suffix of Cl, yeah, mostly Cl and L, okay. So if you see this anti-apoptotic, that is this BCl2, MCl1 and BClXL. BCl2, MCl1 and BClXL. Whereas you should be vigilant in this. There is one more BCl, but it is not XL, it is XS. It's XS. It is a pro-apoptotic in nature. It is pro-apoptotic in nature. Means in your family there will be there, right? In your family or in your relatives or your friends will be there. Someone will be supporting you and someone will be against you. So pro-apoptotic genes are the supportive genes which promotes apoptosis, whereas anti-apoptotic genes, they will be against apoptosis. They will stop this apoptosis, okay. And there will be few people who will sense you, means they can read your faces, right? They can sense and tell you, yeah, you are sad, wow, you are in confusion, you are in FMGE preparation part. So likewise they will see and they will tell you. So these are known as stress sensors, okay. There are few stress sensors and there are few people who will be supporting you that you can do your FMGE examination well, and there will be few people who gives you this enough motivations that they will tell you that you cannot pass, but you know that you will pass. So with this motivation you will proceed ahead that I will show them one day that I can pass this examination. So that is what, that is this three and few concepts like pro-apoptotic genes, which include this back, box, BClXS, remember it is BClXS, then SMAC and D-elbow. Back and D-elbow. So back, box, BClXS, SMAC and D-elbow. These are these pro-apoptotic genes, and anti-apoptotic genes, as I told you, it will be having this Cl in their suffix. So it is what it is, BCl2, MCl1 and BClXL, BClXL. Yeah, good guys. And we know in the case of apoptosis, the marker is what? It is this annexin 5. Then if you see next one, they are known as stress sensors. These stress sensors, they will sense whether is there any stress which is this cell is experiencing. These stress sensors include BIM, BARD, BID, 𝗏, and 𝗃. BIM, BARD, BID, 𝗏, 𝗃. BIM, BARD, BID, 𝗏, 𝗃. So anti-apoptotics will be having this Cl, okay, BCl2, MCl1 and BClXL, okay. Whereas pro-apoptotic will include back, backs, BClXS, SMAC and D-elbow, okay. Whereas this stress sensor includes BIM, BAD, BID, 𝗏 and 𝗃. So these are this stress sensors you need to remember. And as I told you, the marker is what? It is this annexin 5. It is the marker for apoptosis, okay. I will ask you one more annexin 1, just be connected with us, okay. Yeah, we'll use this one more dye which is known as phosphatidylserine, and in the case of extrinsic pathway, we'll use CD95. Yeah, good guys. Next, there are this questions, because we know now there are many of these anti-aging therapies are being underway. So they will be asking this one, which is, which of the following gene is responsible for this anti-aging and this aging, and how it will be reversal, or how will you decrease the progression of aging, okay. If you see, this aging is because of this telomere shortening, okay. Telomere shortening is done by this enzyme which is known as telomerase, okay, telomerase. And mainly this happens due to this free radical injury. We know free radicals like, right, superoxide and the hydroxyl radicals, all of this, they are the free radicals. They will snatch one part of our electrons in our cell membranes and it will cause injury to the cell membranes. Once they cause injury to the cell membranes, then it will cause what? They will destabilize the membrane and it will go for this healing, but it won't heal us properly. So this is known as free radical injury. And how will you decrease this aging or free radical injury? By taking up this free radical scavengers like our vitamins, vitamin C and vitamin E. Then there is this one more thing which is known as sirtuins. Like if we increase the intake or if we increase the levels of sirtuin, then there will be a decrease in the metabolism and there will be a decrease in stress. This leads to this decrease in the aging. Okay, yeah, the red wine. There will be an intake of red wine which is having this high in sirtuins will lead to this decrease in aging, and there will be this blushing, they will tell it, right? And there will be this drugs or this thing which is increasing this insulin sensitivity. Can anyone tell me in the chat box, like what is the GLUT transporter which is insulin dependent? Which is the insulin dependent GLUT transporter? Yeah, good Dr. Anch, it is what it is the, and good Dr. Quinin, the Crazians, yeah, it is what it is the GLUT4. Good, rest of the others, yeah, it is what it is the GLUT4, which is an insulin dependent transporter. Next one, it is the calorie restrictions. Like if you take decreased calories, then there will be a decreased metabolism, the same wise. Then there will be an increased sirtuins. Okay, so the calorie restrictions by around the less than or around 50% less than the usual one, it will lead to this decrease in aging process. And we know there is a syndrome where there is early aging, which is known as Werner syndrome. It is not Werner syndrome, it is Werner syndrome. Remember, it is Werner, okay, it is not Werner, okay. So, agar Werner syndrome hai, it is due to the defect of DNA guidance defect. So, Werner hai, so ye kya? So, it is what it is the DNA guidance defect. Whereas, if it is Werner, it is this M for M, it is the Men syndrome. It is this Men syndrome. Then we will see about few inflammatory mediators. You know, once there is a cell, once it undergoes injury, it need to be repaired. So when it be repaired, before that there will be a process which will be going on, which is known as inflammation. Okay, during this inflammation process, few things will happen. Okay, what are them? Initially, there will be fever, a favorite fever. There will be what? There will be this fever. So we know this fever, it is due to this interleukin 1, 6 and TNF alpha. So three things you need to remember: 1, 6 and TNF alpha. It is for this fever. So 1, 6 TNF alpha, it is responsible for fever during inflammation pause. Okay, so if we give paracetamol, it will what? It will decrease this inflammatory cytokines which causing this fever. Next one, in a case of cancer or in a case of cancer and cachexia patients, there will be a loss of appetite and there will be a weight loss. There will be this weight loss, and it is due to this TNF alpha. So this TNF alpha will cause this cachexia. So TNF alpha will cause this cachexia. Fine, yeah. Interleukin 11, like it also will cause this pyrogen. So especially we'll read about one more process where this interleukin level comes. Okay, I'll guide you guys. Don't worry. Next, if you see about the next one, which is this fibrosis. This fibrosis, if you see, once there is inflammation, it need to heal, right? Once you suffered a heartbreak or something, at some point of time, you should come out of it, right? You cannot stay with some part of your heartbreak and you can take them all your life along, right? So some point you need to heal these things. Yeah, this is for your goodness. You learned big things from it and you should move on. So this type of healing, it comes because of this fibrosis. Okay, during your inflammation, it will be healed by this fibrosis, and this fibrosis is because of this factor which is known as TGF-beta. Okay, oral told beta, they told you that they cause scarring, which is the fibrosis. Okay, like the previous, like beta, B2, they made you to heartbreak and made your heart to scar. Okay, with and memories. Okay, just itna yaad rakho. Okay. Then, if you're able to see the next one, there will be in few conditions, like for example, in a case of tuberculosis, in a case of leprosy, they are what? They are this chronic granulomatous inflammation. Okay, they are what? They are this chronic granulomatous inflammation. So, in such cases, there need to be formation of this granuloma. And this granuloma, it is due to the G for G, it is due to this, so it is what? It is this interferon gamma. It is this interferon gamma. So interferon gamma will lead to this formation of this granuloma. And there are few things, like you cannot eat everything for a very longer time, as I told you. So you need to stop this inflammation after a certain point. So there are few anti-inflammatory cytokines which include interleukin 4, interleukin 6 and interleukin 10. So remember 6 plus 4, it is 10. So all of these three, they are what? They are this anti-inflammatory cytokines. So 6, 4, 10, they are this anti-inflammatory cytokines. And finally, there will be this eosinophils. In the case of allergic reactions, these eosinophils will release histamine, okay, and along with this mast cells. So this eosinophils, it will be brought to there by this cytokine, which is what? Which is the interleukin 5. So interleukin 5, it is responsible for this eosinophilic actions. Okay, I guess most of these things about this initial interleukins is clear. Yeah, repeat granuloma. So if you see in a case of granuloma, there will be this caseating granuloma and non-caseating granuloma. Some disease, it will cure very suddenly or within an ample of time. Whereas some disease, the pathogens, it will having some pathogenic mechanisms which evade from this macrophages, like which will evade from these macrophages or which will prevent themselves from killing. So in such cases, there will be the formation of granuloma. We'll see in further run, there will be this caseating granuloma and non-caseating granuloma. Okay, so to form this granuloma, we need this interferon gamma. So to form this granuloma, we need this interferon gamma. So just these are this few interleukins. Then if you see about chemotaxis, as I told, there is inflammation, but who will tell or how will tell that there is inflammation going on, and these cells need to come there and they need to fight against this inflammation part. So if you see, there is this chemotactic cytokine which is known as CX3. So remember this 3, make this 3 into M. So if you split this 3 into M, it is what it is this. The monocytes and the T cells, the monocytes, especially the monocytes, it will come there because of this CX3. Then there will be this CXC. So remember this X, okay, not your X, see this X. And if you make this X into this is this 8. So make this X, make it to 8. So it is this 8. So remember this 8, it is what? It is interleukin 8, it is at the CXs, and it is because, and it will cause this attraction of this neutrophils. It will cause attraction of which of the following? It cause attraction of the neutrophils, because we know that cells which is predominant during this acute inflammation, it is what? It is the neutrophil. So CX3, 3 looks like M, so it is what? It is monocytes. CXC, so if you make this X into 8, it is what? It is this neutrophils. Yeah, good guys. Yeah, X को कभी नहीं बोलना, बिल्कुल. Okay. Then about CC, you want to know about this eotaxin, rantis, and MCP. Whereas just C, it is what? It is this lymphotaxin. About this lymphotaxin. Okay, and these are the people who will call them. Yeah, come, we need to fight for this inflammation. Whereas there is few more guys. When they saw this microorganisms, what they will do? They will just go and attach over them. For example, okay. For example, when you pass your examination, your friends, your school friends will know, yeah, this guy passed FMGE examination, so we need to get the party. Okay, one friend will start come and attach, and everyone will start come and attaching you, and they will be what? They will be making your journey very peaceful or making you more enjoyable. So what they will do, this opsonin, they will make the food tasty, or they make them to be easily recognizable, okay, easily recognizable for this macrophages. And this, the most important, if you ask me the most important one, it is this IgG. Whereas sometimes they will ask you which of the following complement protein, it is this most important opsinogen. It is what? It is C3b. It is C3b, and there is one more one, it is this fibrinogen. So these, all of them, they are this opsinogens. What they will do, opsonins, what they will do, they will make them easy to identify for this macrophages and other cells. Okay, that is the thing. Good guys. Then about this slides of giant cells. As I told you, this interferon gamma, this here I told you, right? Interferon gamma, it leads to the formation of this granuloma. Interferon gamma lead to the formation of granulomas. And there are different types of granuloma. One of the most common type of granuloma you will see in a case of TB, it is what? It is the caseating, okay, caseating granuloma, okay. And in a case of TB, we know there will be a presence of this giant cells. How will you tell it is giant cells? Because we will tell them this type of giant cells because there will be this multiple nucleated. There will be this multiple nuclei will be there, okay. There will be this multiple nuclei. It's not one, it is this multiple nucleated giant cells. And if you see them, they are not arranged in a circular fashions. They are arranged in this pattern, which is known as what? Which is known as horseshoe pattern. So this type of arrangement of this multinuclear giant cells in this horseshoe pattern. Can anyone tell me what is the name of this giant cells? This type of horseshoe arrangement of giant cells. They will give this slide and they will give this classical history of this TB and they will ask you what is the name of this giant cell. It is what? It is this Langhans. It is Langhans. Remember, there are two cells, Langhans giant cells and Langerhans cells. So Langhans and Langerhans. So remember Langer, okay, Langer. So Langerhans, that is what? Ger for der, means it is a derma cell. So Langerhans cell, it is a derma cell. It is seen in skin, okay, seen in skin. Whereas in TB, you will see this cell which is known as what? Langhans giant cell. Langhans giant cell, and it is horseshoe in shape. And mostly this will show this caseating granuloma. And next, you see a child who with this features of, there is a clinical features of conjunctivitis, coryza. There is a features of this conjunctivitis, coryza, and there is a presence of this part which is known as Popelik's part. Yeah, I am getting the answer. Yeah, it is what? This is the classical history of what? Classical history of measles. And in some cases of this measles may be complicated into a pneumonia. What is the name of this pneumonia which is seen in a case of measles? It is known as what? It is known as hex pneumonia. Good guys. It is known as what? Hex pneumonia. And in the case of this measles, you will be able to see there are two type of intracytoplasmic and intranuclear. This type of both type of this inclusion bodies and this type of giant cells. And if there is this multiple nuclear giant cells along with this inclusions and this type of giant cells, they are known as, what the name of these giant cells, guys? Yeah, it is what it is. Yeah, good. Dr. Ansh, it is what is this? 𝗵𝗵𝗶𝗀𝗀 giant cells. Remember, in measles, you will see this 𝗵𝗵𝗶𝗀𝗀 giant cells. Okay, that's it. Okay, and in measles, the name of the pneumonia which is seen in a case of measles, it is this hex pneumonia. Fine. And next, you see a patient who is presenting with this rash or group of rash over the genitalia. And you did a smear which is known as Zancks smear. And Zancks smear, you will be able to see there is this multinucleated giant cells. Zancks smear showing this multinucleated giant cells, it is not HPV, guys, it is seen in a case of HSV, herpes simplex virus will show this multinucleated giant cells. Okay, so you took a Zancks smear, you will see this multinucleated giant cells. Okay, giant cells. So this is seen in a case of HSV. So there are two HSV, one is above waist HSV, so second is this below waist. So one is above waist, it causes this herpes labialis, whereas this HSV2, it causes this sexually transmitted infections. Okay, it causes this sexually transmitted infections. That's it, guys. Next one about this oval appearance. So they will ask this simple questions here. In FMGE, there won't be always 300 questions are not harder in nature. Okay, if it is 300 questions are harder, then no one will pass the examination. You see your friends, your seniors, they are passing the examination because there will be these easy questions and this game-changing questions as well. So these easy questions you should make correct in these easy questions. That is the game-changing point, and that is the point where it will bring you from 149 to the 150 mark. From this 149 to the 150 mark, it is the easy question. It is not the tough question which makes the difference. It is the easy question which is making this 1 mark and a big difference. Okay, if you see, this is what this is, this oval eye appearance. Okay, oval eye appearance. And how will you differentiate these two oval eyes? If you see, there is this red center or this pink. If you see this red one, remember it is this Reed-Sternberg cell. So red one, it is this Reed-Sternberg cell. So we know this Reed-Sternberg cell which is seen in a case of Hodgkin's lymphoma. So Reed-Sternberg cell which is red in color means the center will be red in color. So it is what it is seen in a case of Hodgkin's lymphoma. Reed-Sternberg cell red in color seen in Hodgkin's lymphoma. Whereas in a case of cytomegalovirus, you will see there is this nucleolus, but it will be what? It will be blue in color. If you see this kind of blue in color, if the nucleolus is blue in color, then it is what? It is the CMV. It is this CMV. So CMV will be having this blue color central or this eosinophilic central. Next one, if you are able to see this type of giant cells, where you are able to see there is this large vacuoles. There is this large vacuoles and there is this surrounding giant cells. So if you are able to see this type of cytoplasm which is containing large type of fats and the materials inside. So it is what? It is known as Q-Tens giant cells. It is known as Q-Tens giant cells, and this type of Q-Tens giant cells, it is most common and classically seen in a case of xanthoma. So Q-Tens giant cells will be seen in a case of xanthoma. Okay, just remember, if you are able to see this type of collection of this fat, it is what? It is the xanthomas which is causing this type of giant cells which is known as Q-Tens giant. Okay, that's it guys. These are this few giant cell images you need to look into. Like horseshoe shaped will be seen in a case of TB, they are known as Langhans cells. Next one, Warthin-Finkel giant cells will be seen in a case of measles, and multinucleated giant cells in snacks like in Zanksmeer will be seen in a case of herpes simplex virus. And next, this olive appearance blue eye will be seen in a case of CMV, whereas red eye will be seen in a case of Reed-Sternberg cell. Will be seen in a case of Reed-Sternberg cell. Okay, and this fat containing cytoplasm 1, it is known as Q-Tens giant cell. It is known as Q-Tens giant cell. Next, we'll move on to these few genes of carcinogenesis. Let me give you the disclaimer. Yeah, these genes will be bit confusing. It will be bit confusing, I know. Okay, but there is no option. You should read it. If it is more confusing for you, what you can do is that you can make a list of it. Like I'll tell you for which things you need to make a list. In pathology, make sure you are making this list for the genes and for this tumor markers. Okay, if you try to make these two things, and few in long run I will tell you, then you just fix them into your wall or into your library part. If you do these things, then what will happen is you will be able to see them in regular basis, and if you see them in regular basis, you will be able to get these things into your mind, and it will be under your subconsciously you will get the fancy stuff. Okay, and I will try to tell you this about this genes. Okay, and about this genes, first we'll see about this growth factor, and this growth factor which includes the first gene, it is this HST gene. So if you see this HST gene, so remember this, make HST into OST. So remember, HST will be seen in a case of osteosarcoma. Will be seen in a case of osteosarcoma. Next one, there are these two genes, cis gene and PDGF-beta. This platelet derived growth factor, they will ask you, platelet derived growth factor will be seen in a case of astrocytoma. Okay, astrocytoma. So HST, osteosarcoma, PDGF-beta, astrocytoma. HST, osteosarcoma, PDGF-beta, astrocytoma. Then this growth factor receptor, this includes this ALK, EGFR1. Remember, it's EGFR1. EGFR1, it is for this adenocarcinoma of lung, whereas this EGFR2, which is what, which is HER2 new. Okay, HER2, both of them it will be positive for this breast cancer, or both of them it is responsible for this breast cancer. So HER2 and EGFR2, it is this breast cancer. You can remember this EGFR2, second alphabet it is this B. So second alphabet it is this B, which is this breast cancer. Next, if you see the next one, this c-KIT or CD117. c-KIT, CD117, you can remember by this mnemonic of Games, you remember it as GIST, AML and melanoma. And finally the seminoma. So GIST, AML, melanoma and seminoma. GIST, AML, melanoma and seminoma, all will be positive for this c-KIT or CD117. c-KIT and CD117, the GIST, AML, melanoma and seminoma. GIST, AML, melanoma and seminoma, it will be positive for c-KIT. Next, this red gene mutation will be responsible for one disease and one multiple endocrine neoplasia. So it is responsible for this disease, which is known as Hirschsprung disease. It is known as Hirschsprung disease, which is what? Which is this congenital aganglionosis. Yeah. Then MEN2A, it is because of this red gene mutation. It is because of this red gene mutation. We will discuss this MEN in our medicine part. And next, about RAS genes. You need to know about this KRAS, HRAS, NRAS. Okay, RAS. Okay, remember RAS or RAS. Okay, if you see this K, remember it as cool lip. You know this cool lip, right? Remember it is the colon cancer, the lung cancer, and this pancreatic cancer. Okay, remember this is 3-1. Colip. Okay, it is this colon cancer, lung cancer, and pancreatic cancer. The 3 cancer: colon cancer, lung cancer, and pancreatic cancer. Next one, it is this 𝗏𝗃. This 𝗏𝗃, it will be causing in, or it is responsible for this kidney tumors and pituitary tumors. So 𝗏𝗃, it is for this kidney tumors and pituitary tumors. 𝗓𝗏, it is this colip, colon cancer, then the lung cancer, and this pancreatic cancer. Colon, lung, and pancreas. Then there is 2 cancers: gene 𝗁 and gene 𝗃. So you remember this 𝗃 means it is responsible for this I1. Okay, so then it is what? Then it is this uveal melanoma. Gene 𝗃, it is responsible for this uveal melanoma, whereas gene 𝗁, it is responsible for this amyotrophic adenoma. Okay, amyotrophic adenoma. Then the final one, it is this BRAF mutation. This BRAF mutation is classically seen in a case of papillary carcinoma thyroid, and in child who is presenting with features of ataxia and vertigo. And on evaluation, you will be able to see in cerebellum there will be what? There will be this cystic mass. The most common site of this pilocytic astrocytoma, it is the cerebellum with this cystic mass. Okay, so this BRAF gene mutation, it is papillary carcinoma thyroid, pilocytic astrocytoma, melanoma, colon cancer, and Langerhans cell histiocytosis, and hairy cell leukemia. Hairy cell leukemia. Okay. Then about the MIC, there are 3 MICs you need to remember: 𝗔𝗵𝗃, 𝗪𝗵𝗃, and 𝗪𝗵𝗃. C, remember it is B, C. So remember after B, the C will come. So okay, Burkitt lymphoma. So 𝗔𝗵𝗃, it is for this Burkitt lymphoma. Can anyone tell me what is the enzyme deficient in a case of Cory's disease? Yeah guys, what is the enzyme deficiency in a case of Cory's disease, the glycogen storage disease? The mnemonic. Yesterday we studied, right? C, D. So Cory's disease, it is what? It is this debranching enzyme. Yeah, water soluble also it is BC. Yeah, it is what? It is this debranching enzyme. Yeah, good guys, it is what? It is this debranching enzyme. Okay, and we know this Anderson disease, it is because of this branching enzyme. Good enzyme. And next, if you see, there is this 𝗪𝗵𝗃. Remember this L for this L. So this 𝗪𝗵𝗃 will be seen in a case of small cell lung cancer. It will be seen in a case of small cell lung cancer. So 𝗓𝗵𝗃, it is for Burkitt's lymphoma, 𝗪𝗵𝗃, it is for this small cell lung cancer, and 𝗪𝗵𝗃, it is for this neuroblastoma and medulloblastoma. So 𝗪𝗵𝗃 for this N and M, neuroblastoma and medulloblastoma. 𝗪𝗵𝗃 for neuroblastoma and medulloblastoma, 𝗪𝗵𝗃 for small cell lung cancer, 𝗓𝗵𝗃 for Burkitt's lymphoma. Okay, and cyclin D1, it is responsible for this mantle cell lymphoma, and CDK4, it is responsible for this glioblastoma. So glioblastoma, it is because of the CD4, cyclin D1, this mantle cell lymphoma, 𝗓𝗵𝗃 for Burkitt's, 𝗪𝗵𝗃 for small cell lung cancer, 𝗪𝗵𝗃 for neuroblastoma and medulloblastoma. And BRAF we told, that is the papillary carcinoma thyroid, pilocytic astrocytoma, melanoma, colon cancer, and Langerhans cell histiocytosis, and the opposite of it is what? It is this hairy cell leukemia. For RAS, it is the KRAS. KRAS, we remember it is colip. It is what? It is the colon cancer, lung cancer, and pancreatic cancer. Next one, it is this 𝗏𝗃. 𝗏𝗃, which include this kidney and pituitary tumors. Next one, it is this NRAS. N, it is responsible for this melanoma and AML. Whereas this gene 𝗃, it is responsible for this uveal melanoma. Okay. Then remember this 𝗏𝗃 for osteosarcoma. 𝗏𝗃, it is for osteosarcoma. Then PDGF-beta, it is responsible for this astrocytoma. ALK and EGFR1, it is for lung tumor, whereas EGFR2 and HER2, it is for this breast cancer. Okay, then one this 𝗏𝗃 or CD117, it is for this GIST, AML, melanoma, and seminoma. Okay, the games one. GIST, AML, melanoma, and seminoma. Okay, it will be a bit difficult for you while reading for this first or second times, but in long run you will be able to get this. So just make sure you are making it into your short notes or into your small sticky notes and sticking into your walls. Okay, then we'll move on to this tumor markers. And about this tumor markers, what is the use? If you see, there are few conditions which you will diagnose radiologically. Okay, there are few conditions you diagnose it radiologically, and those conditions, when you cannot diagnose radiologically, in such conditions you need this tumor marker. Or then if you see this tumor markers, it is mostly useful in a case of tumors which is not radiologically detectable and to know this progression of these tumors. For example, if you see this 𝗵𝗃-HCG, which is this choriocarcinoma. So we know usually we use this 𝗵𝗃-HCG for our pregnancy testing, but in a case of choriocarcinoma, we'll use this same It is what it is, this 𝗵𝗵𝗀𝗀𝗃. So choriocarcinoma will use this 𝗵𝗵𝗀𝗃. And remember, in the case of molar pregnancy also will measure this 𝗵𝗵𝗀𝗃. So 𝗵𝗵𝗀𝗃 for pregnancy testing and molar pregnancy. Next one, if you see this calcitonin, we know there are two cells, follicular cells and C cells in thyroid. So the C cells, it is responsible for this calcitonin, and if there is any tumor of this calcitonin secreting cells, it is what it is, this medullary carcinoma thyroid. It is this medullary carcinoma thyroid. Next one, this catecholamines. This catecholamines and their derivatives, it will be released during this pheochromocytoma. We'll call them as MVA, okay, or metanephrines. And 5-hydroxyindole acetic acid, it is seen in a case of carcinoid tumor. You know, they are this serotonin derivatives. So this 5-hydroxyindole acetic acid, it will be used in the diagnosis of carcinoid tumor. And we know this fetal tumors, this alpha fetoprotein, it is used for the diagnosis of this fetal tumors or this yolk sac tumors. It is what it is, this yolk sac tumor and hepatocellular carcinoma and hepatoblastoma. Hepatocellular carcinoma and hepatoblastoma. All of these things will use this AFP as a marker. So remember, 𝗵𝗵𝗀𝗃, it is choriocarcinoma. Calcitonin, it is this medullary carcinoma thyroid. Catecholamines like metanephrines, it will be used in a case of pheochromocytoma, and 5-hydroxyindole acetic acid, it is used in a case of carcinoid tumor. And AFP, alpha fetoproteins, it is used in a case of yolk sac tumor, hepatocellular carcinoma and hepatoblastoma. Then if you see about the CEA, it is used in a case of colon cancer. Carcinoembryonic antigen, it is used in a case of colon cancer. And PSA and PAP, it is used in a case of prostate cancer. It is used in a case of prostate cancer. And we know in a case of multiple myeloma, there will be mostly defect in this small chains or this light chains, and there will be enormous amount of this immunoglobulin production. So multiple myeloma will use this immunoglobulins as a tumor markers. And neuron specific enolase will be used in a case of neuroendocrine tumors like our small cell lung cancer and neuroblastoma. And for ovarian, it is 125. Remember, it is 125. 125, it is this ovarian cancer, whereas 19, remember this, make this 9 into P. So it is what it is, this pancreatic cancer. If you flip this 9, it is this P, so it is the pancreatic cancer. Next, it is this 3. If you make this 3 like this, it is what it is, same B, right? So CA15-3, it is this breast cancer. CA15-3, it is the breast cancer. And NMP22, just remember this may ask your upcoming examination. NMP22, it is used for this urinary bladder cancer. It is used for as a tumor marker in a case of bladder cancer. Yeah, you identified and you know this progression of the tumors in this blood. But when you given a slide, you need to prove them that this is this tumor, or this is from mesenchymal origin, or this is from this epithelial origin. So to do those, then we'll use this marker which is known as immunohistochemistry markers. So immunohistochemistry markers, they will ask you, there is an epithelial tumor like squamous cell carcinoma, and the following image has been given, and which of the following immunohistochemistry marker you will see in this case. So in a case of any carcinomas, like squamous cell carcinoma, you will see this cytokeratin, C for carcinoma and C for cytokeratin. फिर उसके बाद in the case of sarcoma में क्या देखेंगे हम? Sarcoma में vimentin देखेंगे. So in the case of sarcoma, we'll see vimentin, and in the case of lymphoma में, then we'll see this LCA and CD45. Remember, lymphoma, LCA and CD45. Lymphoma, LCA and CD45. Next one, in the case of melanoma, we'll see HMB45. Then again this vimentin positive, then S100. There is one more thing which is known as S100. Okay. Then about this neurofilaments will be seen in the case of neurons and neurogangliomas, and desmin will be used in a case of myomas or this muscle tumors, and GFAP will be used in a case of astrocytoma and oligodendroglioma and ependymoma. So GFAP will be used in a case of astrocytoma, oligodendroglioma and ependymoma. Okay, so just remember this IHC markers. C for C, cytokeratin will be used in a case of carcinoma. Then we'll move on to this most interesting part, that is this pedigree part. You see, this pedigree part, it looks very much simple, but it is as complex as it is. So if you see in normal during the class times, you will be able to see this pedigree charts, so you will be able to come to the conclusion, yeah, this is the answer. But when you see in the main examination hall, everything looks similar to you. Okay, the option A, option B, option D and option C, all of them it looks very much similar to you. So in such scenarios, you need to have few differential points. Because few differential points होना, तो अगर आपके पास वो few differential points है, then you can come to this conclusion to the earliest. Okay? So to solve this pedigree chart, you need to look into this. கண்டிப்பா தமிழ்ல சொல்லலாம், ஒன்றும் பிரச்சனை கிடையாது, பட் எல்லாருக்கும் புரியும் இல்லையா? Then if you are able to see this pedigree chart, you need to see first there is this thing which is known as gender. Then if you see next one is the generation. Okay, generation. Okay, and first you need to see this gender, next one you need to see about the generation. So if there is any gender bias, if there is any gender bias present, gender bias agar present hai, then it is what? It will be two things, either it is X-linked dominant and X-linked recessive. So remember, who is this dominant species? Is it male or female? Or who is dominant in your home? It looks like that male are the dominant people, right? But actually not. The females are the dominant people. So remember, this X-linked dominant, it will be affecting the females. Okay, it is females to all the sons and are the father to all daughters. Okay, especially it will be mentioned like father to all daughters will be seen in a case of X-linked dominant. Okay, X-linked dominant. So see, this is a female, it is being transferred to this male, and this from this male it is transferred to all these female genders. Okay, only these females are being affected once the male is affected. So it is what it is, this X-linked dominant condition. So it is what it is, the X-linked dominant condition. Then if you see this X-linked recessive condition, then as I told you, the males are recessive. Okay, the females are dominant. So in a case of X-linked recessive conditions, the males will be affected. The males will be affected. Agar if the disease is spreading from a female, it is the female. ठीक है ना, जो भी goal है, female है. Okay, so whichever is in round, it is the female one. It is the female. Okay, agar if it is in a square, it is the male. ठीक है, इतना याद रखो, उधर जाके confuse नहीं होना. Like just make these things simple things. You just remember there you are getting confused in the examination whether this is male or female. Okay, okay. Male will be they won't care about the shapes, right? But females, they are always the figure in shape. So see this circle, it is very much good in shape. So remember the females will be represented as circle. Okay, at the proper shape. Okay, just remember. Then this, if from females to all the males are being affected, then it is what? Then it is the X-linked recessive condition. Right? Then this is this gender bias. If this gender bias is present, okay, yeah, confusion होता तो बस इसको देख लो. अगर इसके हिसाब से आप जाओगे, then you won't get confusion. So that is why there is a sequential. सबका एक step होता है. ठीक है, अगर एकदम से आप कुछ करोगे तो कुछ नहीं होगा. पहले आपको मन बनाना पड़ता है, फिर उसके बाद उसको decode करना पड़ता है. So you should have all these things in your mind. You should go step by step. पहले हमने gender देख लिया. First we saw this gender. If females are affected and the females are affected from the males, then it is what? Then it is X-linked dominant. Or if it is males are being affected and this affected males are being affected from a female, then it is what? Then it is X-linked recessive condition. Then we need to go into this, which is this generation part. Then in a case of autosomal diseases, autosomal one, if you see this autosomal one, there will be no gender bias. No gender bias means both females and males will be equal. Okay, both females and males will be equally affected. Whereas here you need to look into this generation, means how you are spreading to your generations. For example, you passed your FMGE examination, then you need to tell to your juniors like ऐसे करना, means like this you need to do, like this you need to do your preparation part, and that's how you will pass your examination. अगर आपने अपनी juniors को नहीं बताएं, then there will be a gap in the generations, they will tend to fail more. ठीक है ना? So if you see, if there is any gap in the generations, if there is any gap in the generation, if you see this is the affected male and there is none of them they are affected. So if there is any gap in the generations, then it is what? Then it is autosomal recessive. If gap present, then it is the autosomal recessive. Lekin you passed your examination. See, you passed your examination with good marks. Okay, and once you passed, what you did, like is this blue one? Let's see this blue one. So once you passed, or this red one. So imagine whatever you want. Like once you pass this as red one, so just keep you are affected. Once you are affected, or once you pass this examination, you tell your juniors like this you need to pass, or like this you need to do. You tell to the juniors, and he obviously what? He or she will pass. So this will be passed to the next generations, and both males and females, like you won't see like only females I will tell you, only males I will teach you. No, it's not like you should tell to everyone. So in the case of autosomal dominant, you will pass from one generations to the all generations. So your junior, your super junior, all of them will be passed. So if there is a disease which is presenting in this grandparents, grandmothers, and your parents and you, it is what? It is in a sequential and all the generations are affected. So it is what? It is this autosomal dominant in nature. Okay, it is autosomal dominant in nature. Why mother from X-linked dominant, daughter is not affected? See, there is this X-linked conditions, there will be thing which is known as homozygosity and heterozygosity. Okay, to express something, it should be homozygous in nature, whereas in a female it is XX, whereas in male there is only XY. So if only one chromosome, if it is coming from female, which is this X chromosome, then it will obviously come and manifest to the patient or to the person or to the next generation. Whereas in females there is 2X. One will be coming from mother and one will be coming from father. So only one will be expressed. So there won't cause any disease in females. Okay, so mother cannot give disease to them. Whereas the mother will give obviously her X to this child. So that's why the male child will be affected in a case of X-linked dominant condition. Okay, so that's what. So X-linked, first you see gender. If there is any male gender affected, it is their recessive gender. So it is X-linked recessive. If it is female gender affected, it is X-linked dominant. And if there is any no gender bias, but all the generations are involved, then it is what? Then it is autosomal dominant. And if there is a skipping in generations, then it is what? Then it is the autosomal recessive. Then it is this autosomal recessive. Keep in mindset, whatever you have, it is you are having. It is not your friend or your Padosi is having, that it means it is yours. So if you see in your exam, these questions will be asked, and it looks like all of the generations are being affected. See, this is the affected one, this is the affected one, and I told you these are the three unaffected children. Whereas there's someone from other family or from outside, they are getting married. So don't consider this outside peoples as you or as your family. Okay, neighbors will always stay as neighbors. Okay, so have a limit in them. So the same way, if you see, if they are affected but they are coming from outside, so they are not considered as generations. So the generation of this are this three, and these three are unaffected. So it is autosomal recessive. Don't have confusion in it. Okay, yeah, that is, if you ask me, can means in medicine everything is can. Okay, in medicine everything is can, but most commonly we are speaking, because this exam is based on the most common and the most easiest things. For example, they will ask you TB because we are having more cases of TB in India. Okay, that's why. And the most common are this in a case of dominant, X-linked dominants, the most commonly affected, they are the females. Okay, that's it. Next, if you saw a female who is giving all his generations the disease, but when it comes to the male, it is not being given to the other generations. So what is this type of inheritance? What is this type of inheritance? If a female is transferring to all his child, whereas this male is not transferring to this next generation, it is what it is, this mitochondrial inheritance. Mitochondrial inheritance. Okay, if you have any more doubts, just make sure you are keeping with you. We'll discuss about it at the break. Okay, so it is what it is, the mitochondrial inheritance. So to know this, you just see this, all these diseases, these are this autosomal dominant and autosomal recessive diseases. If you are able to remember them, well and good. If not, just remember few things. Autosomal dominant conditions, they will involve this structural genes especially. For example, in a case of Marfan's, there will be this involvement of this elastin genes, whereas in a case of dystonia and osteogenesis imperfecta, there will be this involvement of this collagen. So if there is any structure defects, it will be usually autosomal dominant in nature. Whereas if there is any enzyme defect, it will be usually autosomal recessive, like our phenylketonuria, alkaptonuria, then sickle cell anemia, thalassemia, and especially this alpha-1 antitrypsin deficiency, and all our glycogen storage disease and lysosomal storage disease. All of them will be autosomal recessive in nature. Whereas few conditions it will have add-on, like sickle cell anemia, thalassemia, cystic fibrosis, hemochromatosis, and Wilson's disease. They are also autosomal recessive in nature. So if you're not having any clue, if there is any enzyme deficiency, mostly it will be of autosomal recessive in nature. If there is any structural defect, it will be autosomal dominant in nature. Okay, इतना याद रखो. फिर इसके बाद there will be few conditions which are actually enzyme deficient, but they have this exception. So example, this G6P deficiency, this Hunter's is, yesterday we discussed it, Hunter will be having this clear cornea and they need to aim it. So when you need to aim, you will put a cross. So if you are able to see this cross, means it is X. So Hunter's disease will be having this clear cornea and the X-linked recessive inheritance. And the X-linked dominant is, remember this 4 conditions, which is this Ravi. Okay, which is Ravi, which is Red syndrome, Alport syndrome, vitamin D deficient or vitamin D resistant rickets, and incognitia pigmenta. Okay. Then about this few diagnostic techniques. We see about this diagnostic techniques, like these are used to analyze this genetic syndromes. The first one, it is the karyotyping. Can anyone tell me what is this karyotype tells you? It is trisomy of which chromosome? It is the trisomy, good. It is the trisomy of 21, which is this Down syndrome. So it is what? It is this trisomy of 21, which is this Down syndrome. And next, if you see in this karyotyping method, we cannot see everything. Like we can see means if something is visible or gross, we will be able to see it. Whereas if there is any small translocation, or if there is any mutation part, then we cannot find it. With this karyotyping. तब हमें क्या करना? तब हमें एक दूसरा इन्वेस्टिगेशंस करना है, उसका नाम है फिश फ्लोरेसेंट in situ hybridization. Okay, so we'll see like how about the genes, how about whether they are normal or not, or if these two genes, if they are getting fused together. So if there is any fusion of this two genes, so here these genes are separate. First see here the genes are separate, whereas if these two genes they fuse together, it leads to this translocation and fusion. So if we see this translocation or BCR-ABL fusion, you will see this BCR-ABL fusion in which condition? You will see in a case of CML. And next, we have one more condition, which is known as what? Which is known as comparative genomic hybridization. In a case of comparative genomic hybridization, we compare with these normal individuals whether there is a loss of gene or there is a gain of gene. Remember, the yellow one, these are this normal one. Okay, whereas this red one, it is the gain. So remember, it is the red one which is gain, and the green one, it is this loss of function. Red one, it is the gain, and green is the loss of function, right? And next, we'll move on to the next topic, which is this amyloidosis. This amyloidosis, it is what? It is simply, they are the proteins which deposited into this extracellular matrix. This is this extracellular deposition of this amyloid proteins, okay? Amyloid proteins, and usually it will be in this beta pellated sheet. It will be usually deposited in this form of beta pellated sheets. And next, this amyloidosis, it won't see organs, it won't see organs and deposit. It will go and deposit into the organs whichever you want. If you just go and deposit into this kidney, so it is what? It is known as waxy kidney. Okay, waxy kidney, and this will be leading to this nephrotic syndrome. Whether if it is deposited into the heart, it will cause what? It will cause this restrictive cardiomyopathy. And GIT, it will lead to this hepatosplenomegaly. And skin, the skin will be waxy thickening. The skin will be like wax thickened, like there is a thickening, right? There will be waxy thickening, and it will be easily bruisable. And neurologically, it may accumulate near to the nerves and can cause compression, which is the carpal tunnel syndrome. And there are different types of amyloidosis. Primary amyloidosis, it is this our famous multiple myeloma, which is due to this mutation in this light chains of this immunoglobulins, right? And next one, what is this secondary amyloidosis? And this secondary amyloidosis means it is because of some other conditions, and they have a specific type of amyloids. If you see this type of AA type of amyloid, yeah, in the case of carpal tunnel syndrome, the nerve which is being involved, it is this median nerve, and we know this, if there is any median nerve involvement, there will be this Benedict's hand, and there will be this pointing index formations will be seen in the case of median nerve injury or median nerve compression. Okay, and next one, it is this secondary amyloidosis. In the case of secondary amyloidosis, as I told you, there will be what? There will be different types of amyloid deposition. So if you see the first one, it is AA type of amyloid, will be seen in a case of familial Mediterranean fever and other chronic inflammatory conditions. And next one, it is this ATTR. Okay, it is this transthyretin kind of one. If it is getting deposited, which is normal one, then it will be mostly deposited to the heart. If it is mutated type of TTR, if there is any deposition of this mutated type of this transthyretin 1, then it lead to this familial amyloid polyneuropathy. It lead to this familial amyloid polyneuropathy. And next, the most important one, and usually they will ask you, which of the following condition it is being associated with this beta-2 microglobulin. Beta-2 microglobulin, it is associated with this dialysis patients. So dialysis patients, they will be having this amyloidosis, especially or this peculiarly this beta-2 microglobulin. Okay, and in the case of Alzheimer's disease, you will be able to see this beta amyloid. Beta amyloid in amyloidosis in Alzheimer's disease, whereas in the case of beta-2 amyloid or beta-2 microglobulin will be seen in the case of dialysis. AA will be seen in the case of familial Mediterranean fever. Okay, and AIAPP will be seen in the case of diabetes type 2. It is the type 2 diabetes mellitus. It is the type 2 diabetes mellitus, where you will see this isolate amyloid polypeptide type of amyloid deposition. And next, ACAL. We discussed there are two cells in this thyroid. There is this follicular cells and C cells which produces this calcitonin. And if there is any mutation or if there is any tumor, it is what it is this medullary carcinoma thyroid. And there will be deposition of ACAL. Can anyone tell me what is this? What is the tumor marker you will use in a case of medullary carcinoma thyroid? It is what it is this calcitonin. So medullary carcinoma thyroid, it will be associated with this calcitonin, and for to diagnose this we will use this calcitonin. Okay, and there will be this ACAL deposition. And we know this amyloidosis, but we won't accept it, right? Like, because you are a doctor, you tell them fever, common cold. No, I won't accept. I need to see them. I need to see the patient. But if you see a pathologist, they need to see and tell you. They need to see and then only they will confirm you. So, you will stain this amyloid. So, stain this amyloid, you will use the stain which is known as Congo red. And if you stain this amyloid with this Congo red stain, and if you look under this normal light microscopy examination, you will be able to see this type of common pink color, okay, in a normal light microscope. Whereas you kept under a specialized polarizing microscope, you will see this apple green birefringence, okay, apple green birefringence, okay. That is the thing you need to know about this amyloidosis. Next, if you see, there is this photosensitive rash which is especially on this space, around this space, and it is sparing this nasolabial fold. So it is what it is, this classical definition of SLE. And to diagnose SLE, a few antibodies will use. Which of the following antibody will use, which is both sensitive and specific? It is this anti-dsDNA antibody, and the most sensitive one, it is this anti-nuclear antibody, whereas the most specific one, it is this anti-Smith antibody. So anti-ANA and anti-Smith antibody, which is the most specific one for both, that is what it is, anti-double stranded DNA antibody. And in the case of neonatal will cry. So cry ko Hindi mein kya bolte? Rona. So rona. Okay, so neonatal lupus, it will be having this positivity for this pro antibodies. And if there is any psychosis, remember psychosis P4B, it will be involving of this anti-ribosomal P antibody. So most specific, and it is the Smith. Both specific and sensitive, it is double stranded DNA antibodies. Rona, if it is involving neonates and children, it is anti-Ro antibodies. Whereas if it is involving this psychosis or neurological system, it is anti-ribosomal P antibody. Okay, and in CVS, it may cause deposition into this cardiac valve, causing this 𝗵𝗵𝗀 endocarditis. And then kidney, it will cause this type of arrangement, which is called known as, and fluoroscopy, you will be able to see all the antibodies will be present. It is known as full house effect. It will be seen in the case of lupus nephritis. And here you will be able to see this wire loop lesions. Okay, that's it, guys. That's what mainly from pathology perspective we need to know about this SLE. तो इसके बाद आगे बढ़ते हैं hypersensitivity reactions. You know there are different types of hypersensitivity reactions. Type 1, it is what? It is just this simple allergy. तो allergy में क्या क्या हम include करेंगे? Allergic rhinitis, allergic dermatitis, pink attack, which is this vernal keratoconjunctivitis, and atopy, like penicillin allergy, okay, initial part of penicillin allergy, and this Cassoni test, which used for this Echinococcus granulosis, okay, the dog type one. Next one, that is what this mainly is allergy reaction, which is IgE mediated. IgE mediated. फिर उसके बाद आगे बढ़ते हैं type 2 hypersensitivity reactions. Yeah, type 2, yeah, it is mainly of blood related. Whatever is this, like blood transfusion reaction, autoimmune hemolytic anemia, ITP, all of them, they are what? They are this type 2 hypersensitivity reactions. And rheumatic heart disease, the initial part, there will be this molecular mimicry, it is also type 2 hypersensitivity reactions. And this Graves disease and myasthenia gravis, previously they are known as type 2, now it is type, okay. And there is this syndrome which is known as Wood-Pastor syndrome, okay, but it's antibody against this glomerular basement membrane, okay. And also this hyperacute rejections because of this pre-formed antibodies, it is also type 2 one. Next, if you see this type 3, that is this Arthur's reaction and reactive arthritis and this 3-word vasculitis like SLE, PAN, polyarthritis nodosa, HSP and PSGN. Okay, PSGN. So remember, rheumatic heart disease, it is due to this molecular mimicry. So molecular mimicry, it is type 2 hypersensitivity reactions. Whereas post-streptococcal glomerulonephritis, it is what? It is this type 3 hypersensitivity reactions, which is because of this immune complex deposition. It is this immune complex deposition. So see, someone comes, you will just send IgE and it is allergy. Whereas you see, send this antibody against a specific receptor. So it is what? It is this antibody mediated. Whereas here, there will be this antibody and someone else will come in. But what they will do, instead of attacking, what they will do, they will just sit and chit chat. There is this deposition. They will come and deposit like this. Okay. So it is this type 3 hypersensitivity reactions. Whereas type 4, it is what? It is this late or this lymphocyte mediated. So this includes like our Montauk's test and Lepromin test and our famous contact dermatitis. Remember, this allergic dermatitis, it is the type 1, whereas this contact dermatitis, it is what? It is this type 4 hypersensitivity reaction. Then we'll move on to the next part. It is this rheumatic heart disease and the endocarditis. Okay, it is one of the hot topic. It is being tested multiple times and more frequently. They will give you this image and they will ask you, what is the name of this body? Okay, so what is the name of this body? I'll give you 5 seconds. Think and tell me. It is what? It is this Ashchoff body. It is known as Ashchoff nodules especially. Okay, Ashchoff nodules. And here you will be able to see this type of cells and cross section. They are known as caterpillar. Okay, they are known as, see, it is like a caterpillar, right? It is known as caterpillar cells. Next, if you see, there are few criteria you need to know. So to know about this criteria, you know what is the name of the criteria? It is the Jones criteria. So J for G, it is the joint involvement, and next one it is the O, like how we made for Pompe's disease, right? Pompe's O will make them into hot. Okay, will make them into hot. So take it, जैसे हमने दिल बनाए, वैसे Jones it is causing in rheumatic heart disease, उसको भी हम दिल बनाएंगे, तो it is what? It is this pancarditis. So Jones O for O, it causes this pancarditis. Next, it causes this subcutaneous nodules, which are usually painless, and erythema marginatum. So it is the Jones, okay, nodules, and for nodules and erythema marginatum and Sydenham's chorea and next one is the chorea. I told you, right? Chorea, Sydenham's chorea. And if there is any chorea, it will involve which of the following cranial nuclei? Yeah, guys. If there is any involvement of this chorea, yesterday we studied in anatomy, right? What is the name of the nuclei? HLF, you have already this. Yeah, it is what? It is this caudate nucleus. It is this caudate nucleus. It is the caudate nucleus. Next, there are few minor criteria you need to think of. Fever, polyarthralgia, there will be increased PR interval, and ESR and CRP will be raised. And there will be this valve involvement. The most common valve, we know the most common valve to be involved in a case of rheumatic heart disease. It is what? It is this mitral valve. So in a case of acute rheumatic heart disease, there will be this mitral regurgitation, whereas in a case of chronic, there will be this mitral stenosis. And we know when there is this mitral regurgitation, the blood will come back. When the blood is coming back, it will come and cause a lesion over this left atrium. It is known as McCullum's patch. Fine. Then here you will be able to see a cell which is known as Aniskov's cells. Okay. Then about this infective endocarditis, yeah, there will be able to see this fish mouth valve as well. Yeah. When there is this mitral stenosis will be overwhelmed, there will be small opening will be left. That is known as fish mouth or this buttonhole valve. Next, we see about this infective endocarditis. There is a criteria which is known as Duke's criteria which will use to diagnosis. Okay, and the main major criteria is what it is this positive for this blood culture, and it will be having this investigation findings, the suggestive investigations like you do echo and you will be able to see large visitation. Then it is what? Then it is infective endocarditis. Okay, and the minor criteria include this temperature and our two phenomena, immunological phenomena and this vascular phenomena. So the immunological phenomena, it is this Roth spots and the Osler nodes. Remember the Osler nodes, they are the painful. So Osler nodes, it will be painful nature, whereas Janeway lesions, they are painless in palm. Painless, तो इसलिए वो क्या होता है? Palm में होता है. Remember, okay? And next, how will you differentiate based on this type of lesions? So as I told you, in a case of infective endocarditis, there will be this large lesions. Sometimes they will break into small and can cause into an emboli. So if you are able to see this large bulky lesion, so it is this infective endocarditis. Whereas if you are able to see this type of lesions, which is occurring on this both side of the wall, if it is occurring on the both above and below of the wall, it is known as 𝗵𝗵𝗶𝗀𝗀 endocarditis. Today we studied where we will see this 𝗵𝗵𝗶𝗀𝗀 endocarditis. Yeah guys, 𝗵𝗵𝗶𝗀𝗀 endocarditis will be seen in a case of SLE. Okay, it will be seen in a case of SLE. Right? Whereas in a case of rheumatic heart disease, we will be able to see small, prim and friable vegetations. Good guys. Whereas there is also one more thing which is seen in a case of like tumors, like non-bacterial thrombotic endocarditis, which will be mostly seen in a case of leukemias. Next, about this vasculitis component. Okay, about this vasculitis component, if you see, there will be a old age male who is presenting with complaints of headache. And on evaluation, you will be able to see there is this some mass which is palpable on his temporal lobe. So sometimes it will be associated with this ophthalmic nerve involvement. So there is this old age male presenting with this sensation and presenting with this pain on his temporal aspect, and there is this thickening of some structure. So it is classical feature of giant cell arthritis. And in the case of giant cell arthritis, you will be able to see there is the fragmentation. This is the elastic lamina, and there will be this fragmentation of this elastic lamina, which is especially this internal elastic lamina. फिर उसके बाद you will see this young smoker who is having these features of this blackening of his fingers. These fingers became black or becoming auto amputation in a young smoker, especially this tip of fingers and tip of the toes. It is classically seen in a case of Burgess. Remember Burgess, U for U. Remember U, the next alphabet is V, so it is the vasculitis component. And in a case of Burgess disease, there will be involvement of both arteries, veins and nerves. So this will cause occlusion of them and it will cause inflammation over it. So Burgess disease, it is this involvement of this artery, veins and nerve. And next, if you are able to see, you will unable to see the pulse of a child, and the disease which is known as pulseless disease, it is what it is this 𝗓𝗏𝗏𝗏𝗏𝗏𝗓𝗏𝗏𝗓𝗏𝗓𝗏𝗓𝗏𝗓𝗏𝗓𝗏𝗓𝗏𝗓𝗏𝗓𝗏 Okay, it will most commonly involves this subclavian arteries. Okay, it will most commonly involves this subclavian arteries. Okay, just remember, it will most commonly involve this subclavian artery. So this one, which is 𝗓𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏 like it won't involve continuously, it will be having this segmental involvement. It will be having this segmentally it will involve. There will be sparing will be there. Okay. What is this? Polyarthritis nodosa. And remember one thing, in the case of polyarthritis nodosa, there will be this 𝗵𝗶𝗀𝗃 will be positive in almost 30% of cases. This polyarthritis nodosa, they will be positive for 𝗵𝗶𝗀𝗃. And next, you say a child with this clinical features of this cream. There will be this conjunctivitis, then there will be this erythema and hand and foot edema, and along with this maculopapular rash, and along with this mucosal involvement like strawberry tongue. All of them, they are classically seen in a case of Kawasaki disease. Just remember. And in Kawasaki disease, you will be able to see this anti-endothelial antibodies. Right? And there is one more disease which is microscopic polyangiitis. Just remember, there will be, in a case of microscopic polyangiitis, there will be positive for this 𝗶_ANCA. 𝗶_ANCA will be positive for microscopic polyangiitis. Okay. फिर उसके बाद you say child who is presenting with features of this rash over lower limb and buttocks with this palpable purpura. A child with features of this palpable purpura, and there is this abdominal pain sometimes. Abdominal pain, all of them, they will be suggestive of which disease? Yeah guys, good. It is what it is, this HSP, which is this phenol purpura. Okay, and we know in a case of vaginous granulomatosis, there will be involvement of this 3. The urine will be involved, lung and the cough will be involved, and the blood vessel. Okay, so there will be this lung, kidney, blood vessel involvement along with this perforation of this nasal septum. And remember, vaginous granulomatosis is one of the granulomatosis is having the C-ANCA positivity. So C-ANCA positivity will be seen in a case of vaginous granulomatosis, whereas P-ANCA will be seen in a case of microscopic polyangiitis. Okay, microscopic polyangiitis will see this P-ANCA. Okay, next, if you are able to see the next one, which is this asbestosis. Okay, asbestosis, remember asbestosis, it is this base of the lung. It is what? It is the asbestosis, it involves this base of the lung. So it will involve this base of the lung, and mainly this asbestosis, it will be what? It will be having this involvement of this pleura. It will be having this involvement of this pleura. So once there is an involvement of this pleura, it leads to the formation of this pleural plaques. It leads to the formation of this pleural plaques. Okay, and on evaluation, if you see, you will be able to see this type of bodies which are known as asbestos bodies, also known as ferruginous bodies. And we know there is a stain which we use to stain this iron. Okay, iron will use a stain which is known as what? Pearl's Prussian blue. So this ferruginous bodies means it has iron. So to stain this, we can use this iron stain, which is this Pearl's Prussian blue. Okay, which is what? Which is this asbestos bodies, which is dumbbell in shape, which will be dumbbell in shape. Okay, and it causes few cancers like adenocarcinoma, which is the most common one, whereas the most specifically it causes this mesothelioma. It causes this mesothelioma. And next about sarcoidosis. Sarcoidosis, it causes this non-caseating granuloma. Okay, it causes this non-caseating granuloma. We discussed in tuberculosis, it causes this caseating granuloma or caseating granuloma, whereas this sarcoidosis will cause this non-caseating granuloma, and it will be naked. So it's not like dressless or without dress. See, the granuloma, it will be surrounded by this T lymphocytes, whereas in a case of, yeah, good guys, whereas in a case of sarcoidosis, there will be no T lymphocytes here. So that's why it is known as naked granuloma, and it will be having a syndrome which is known as Ropgen syndrome. It will be having the features of joint pain, fever, and erythema nodosum. So 3 features: joint pain, fever, and erythema nodosum. And here there will be an increased level of calcium and ACE. So to diagnose the sarcoidosis, we'll use this calcium and ACE levels. Next, CD4 and CD8 count, both of them will be elevated in the case of sarcoidosis. And it has 2 bodies. The star-shaped one, that is known as asbestoid body or asteroid body. And next one, the circular one, which is actually this calcium deposition. It is what it is, this 𝗏𝗏 bodies. Okay, it is what it is, this 𝗏𝗏 body. And then we'll move on to this lung tumors. Like, it is the hot topic because the prevalence of smoking, it is being increased very long, and you know this air quality, the air quality of Delhi is being very decreased. Then it can lead to this activation of this oncogenes and can lead to this tumor. So they can ask you in future, right, or ask you in this upcoming examination. So you saw this type of walling like an onion peel. It is what it is, this keratin pulse. The keratin pulse will be seen in the case of squamous cell carcinoma, and it is due to the mutation of P53, and it will be having the positivity for this P63 and P40. We told, right? We need to confirm it. I am a pathologist, right? I need to tell, yeah, this is correct. Okay, so this P63 and P40 will be positive for this squamous cell carcinoma, and it causes this paraneoplastic syndrome, which is this just this hypercalcemia. Okay, whereas if you are able to see, there is this formation of this glands. So this gland formation will be seen in the case of adenocarcinoma. We already saw there is this EGFR1 mutation, KRAS mutation, cool lip we learned, right, and this ALK gene mutation. All of them will cause this adenocarcinoma. And this for immunohistochemistry, we will use this napsin, NUC1 and TTF1. Napsin, NUC1 and TTF1, and it will cause this one paraneoplastic syndrome, which is known as migratory thrombophlebitis. Here there will be vein inflammation, and tomorrow if you see, it will be here, and day after tomorrow if you see, it will be here. So it will be like this. And next, if you are able to see these small tumors, cells, they are having these neurosecretory granules, and if it involves these blood vessels, and if they are transported along these blood vessels, they are what? They are this small cell lung carcinoma, and it is due to this 𝗵𝗃, and it is due to this 𝗵𝗃, okay, and it will be having this salt and pepper chromatin, and because of this involvement of this blood vessel or this penetrating into the blood vessel, we'll call them as azopadi, we'll call them as azopadi, party chal raha, okay. So remember, party chal raha, to sabko andar to aana hai na, so this tumor cells, they try to enter into the blood cells, so it is what is known as azopadi effect, okay, party chal raha, okay. Remember, the paraneoplastic syndromes, which includes this SAADH, Cushing syndrome, and Lambert-Eaton syndrome, okay. There are three syndromes: Cushing syndrome, SAADH, and LES, right? And next day itself, we discussed this Barrett's esophagus. It is what it is, just the metaplasia, which is this intestinal metaplasia, means there is this columnar cells along with this goblet cells. हमें पता है goblet cells है, लेकिन क्या है? मैं pathologist हूँ. I'm a pathologist, and if I'm a pathologist, I need to see them visually. ठीक है? Until unless I see them visually, I won't trust them. I won't trust with Instagram chat, right? So you need to see the stain, which is known as what? Which is known as this Alchian blue stain. It stains this acidic mucin, okay, which is present from this goblet cells. बस इतना याद रखो, ठीक है? So normally we'll be able to see here. This is how this normal stratified squamous epithelium, and here this is this intestinalized epithelium, which is having this goblet cells and this columnar epithelium. So this is the typical Barrett's esophagus, and we know Barrett's esophagus causes which type of cancer? Not acid fast. It will cause which type of cancer? It will cause this adenocarcinoma. Adenocarcinoma. Next we'll move on to this disease, which is the celiac disease. So say a patient is presenting with features of diarrhea, and you ask, what did you eat? The patient still, he ate this, any of them, barley, rye, oats, or wheat, like a chapati he ate. So after this, he's having these features of diarrhea, weight loss, malabsorption. Then you plan to do this examination. Then you found out he's having this susceptibility of this 𝗔𝗔, and you took up a duodenal biopsy. There you will be able to see this first thing, that this villi, it will become atrophic. Usually it will be like this, like a happy, like you, but it became very sad. Means that this villus atrophy, because there is this hyperplasia. This hyperplasia, it is known as crypt hyperplasia, and along with this crypt hyperplasia, there will be these small cells which will be surrounding them. They are what? They are actually this CD8 lymphocytes. So there will be this crypt hyperplasia, villus atrophy, and this CD8 lymphocytes. All of them will be seen in a case of celiac disease. So here you will be able to see few antibodies as well. The most sensitive one, it is this anti-tissue transluminase antibody, whereas in the case of most specific one, it is this anti-endomysial antibody. This anti-endomysial antibody, it is the most specific one, whereas most sensitive one, it is this anti-TTG antibody. It is this anti-TTG antibody, remember. Next one, if you see this next disease, it is what? It is this Whipple's disease. So if you see about this Whipple's disease, the same features of malabsorption, there will be involvement of the systemic involvement, but when you do this biopsy, you will be able to see this only one feature, which is known as what? Positive macrophages. This positive macrophages, which will be having this Treponema Whipple'i bacilli. So this positive macrophages, it will be especially seen in a case of Whipple's disease. Okay, it is this foam cells, which are this macrophages, they are positive. And next about this tumor, could correct that eventually, it is positive. Next, if you see this tumor, which is known as what? Gastrointestinal stromal tumor, and this tumor, they have love to it. Okay, if you see, it will be originated from this cells of Kajal, and it will be having this games mutation. We discussed, right? 𝗔𝗵𝗃 or CD117. What are the games? We'll see the GIST, AML, melanoma, and seminoma. So here it is what? It is this CD117 and 𝗔𝗵𝗃 mutation, which leading to this GIST, and what it will cause? It will cause this increase the activity of this tyrosine kinase. So treat this, will give this imatinib. And as I told you, the marker is CD117 and 𝗔𝗵𝗃, and there is also CD34 as a marker, but the most specific one, it is the dog one. It is the dog one. Okay, it is the dog one. Okay, remember. Next, we'll move on to this few urinary stones. If you see this type of hexagonal shape, that is what it is, this cystine. And if you see this type of coffin lid, coffin lid, it is seen in a case of what? It is seen in a case of true white or triple phosphate stones. Good. Then if you see this type of envelope shaped, then it is what? It is the calcium oxalate dihydrate. Okay. Whereas if you see this type of dumbbell, it is what? It is the calcium oxalate monohydrate. Okay. So sometimes you will be having this confusion about this monohydrate and dihydrate, right? So remember, if you are single, then what you need to have? If you are single, you need to have two things to become mingle. Okay, remember. So you need to have a good face or you need to have a good muscular structure. So obviously, not everyone will be having a good face and charismatic face. Then you plan to build your body. So how will you build your body? You will take up this dumbbells. Okay, so you are single, that's why you are lifting your dumbbells. So remember, it is calcium oxalate monohydrate which is having this dumbbell shaped. And once you become committed or mingle, then what you will do? You need to increase the love. How will you increase the love? You will send the text. Now you are sending your Insta and Snap. Whereas now, previously what they used to do, they used to send the letters or this envelope. So remember, between these two, you need to have a communication. So if two are there, okay, if two are there, then you need to make a communication. You will make communications with this letter. It's actually what? Which is this. If you are able to see this communication between these two males and females, then we'll send the letter. So it is what? It is this envelope shaped crystals. This envelope shaped crystals will be useful or will be seen in a case of calcium oxalate dihydrate. So I guess you will remember, if you are single, you need to lift weights and you need to build your body, that is the calcium oxalate monohydrate. Whereas in a case of calcium oxalate dihydrate, you need to increase the love by sending letters, that is this envelope shaped crystals will be seen in a case of calcium oxalate dihydrate. Okay. Then this shapeless, not shameless, it is the shapeless ones or this rhomboid shapes will be seen in a case of uric acid crystals. Okay. Yeah, okay, yeah, fine. Yeah, you can also remember like this. You are going to gym, picking up the dumbbell to lift the mona to the bed. Okay, just remember. Next, if you are able to see this type of cast, which is normally seen, it is known as what? It is known as hyaline cast. Next, if you are able to see this muddy brown cast, then it is what? It is the acute tubular necrosis. So in a case of acute tubular necrosis, you will be able to see this muddy brown cast. Next, if you are able to see this WBCs, it will be classically seen in the case of any type of nephritis. So any infection. So this is like a vehicle. Okay, as we discussed yesterday, right? What we discussed? We discussed about this SGLTs. Okay, it is like a transporters. So likewise, this cast also is also a transporter. If no one is there, it will go empty. That is what? That is this hyaline cast, which is white in color. Whereas if you are sad or if there is a necrosis, it will take up the excrete or the mud. So it will show this muddy brown cast. Next, if there is any inflammation, we know inflammation, WBC will increase. So in a case of nephritis, there will be this WBC cast. Whereas in a case of nephritic syndrome, okay, or any bleeding things will be there, it will take up the RBC. Okay, it will take up the RBC. Okay. Next, if you see, if there is any clear cells are there, and there is a features of this mass in the kidney associated with these features of hematuria. Okay, this will be suggestive of RCC. This will be typically suggestive of this clear cell RCC. And remember, C for C, it involves this third chromosome. It is a third alphabet. It involves this third chromosome. And next, if you are able to see this type of plant cell appearance, it will be seen in a case of chromophobe RCC. And in the case of chromophobe RCC, we will use a stain which is known as Hurl's colloidal iron stain. We will use this Hurl's colloidal iron stain. Yeah, guys. Hurl's colloidal iron stain. And you also see there is one more syndrome which is known as Bird-Hawk-Dewey syndrome. Bird-Hawk-Dewey syndrome will be seen in a case of chromophobe RCC. And as I told you, this clear cell RCC will be having this clear cells and there will be association with this von Hippel-Lindau syndrome, VHL. In the papillary carcinoma, it will involve this chromosome number 7, and medullary RCC, it will be seen in a case of sickle cell anemia patients. And this RCC will be having a paraneoplastic syndrome, means there will be this interleukin-induced hepatic damage. It is not because of metastasis. This interleukin-6 induced liver dysfunction. It is known as Stoffer syndrome. And if you are able to see this type of central stellate scars of RCC, it is what it is this oncocytoma. It is oncocytoma. Okay. And now we'll do about the CNS. CNS after we'll do hematology and mostly we'll be done with it. Okay. That's it. Okay. So just have patience for a few more time. Then after that we'll take a break. Fine. If you see about the CNS tumor, mostly you need to diagnose it. If you see the first one, it is the meningioma. In meningioma, there will be this O-ring will be there. So it is what it is this, our common 𝗓𝗵𝗶 bodies. So meningioma, you will see what? You will see this 𝗓𝗵𝗶 bodies, and it will be hormonal receptor like progesterone receptor positive. And next you will see this glioblastoma multiforme. And as I told you, this glioblastoma multiforme, it will be involving this both lobes of the brain. Okay, both lobes of the brain will be involved because of the involvement of this corpus callosum. So there is the involvement of this corpus callosum. So it will transfer to this both lobes of the brain. So because of this transfer to this both lobes of the brain, radiologically you will be able to see like a butterfly. You will be able to see like a butterfly tumor, and this is due to the mutation of IDH, isocitrate dehydrogenase mutation. Next, there are two rosettes you need to know: this Homerite pseudo-rosettes and Flexner-Ventesner rosettes. So remember, in retinoblastoma, the most common sign in a case of retinoblastoma, it is what? The whitish people, which is known as what? Which is known as leukocoria. So the similar way, retinoblastoma rosettes will be having this central white. So it is known as Flexner-Ventesner rosettes. It is known as Flexner-Ventesner rosettes, which is seen in a case of retinoblastoma. Whereas pseudo rosettes will be having this pink in color. Okay, pink in color. Okay, this includes this medulloblastoma, Ewing sarcoma, and neuroblastoma. Medulloblastoma, Ewing sarcoma, and neuroblastoma will be having this Homerite pseudo rosettes. You can remember this. Men are the pseudo people, right? They are the very false people. Or else, if you are men, then you can remember like you won't live for yourself. You will live for the people in your heart. Obviously, in your heart there will be two pink peoples. One is your mother, and other one is your girlfriend. So it is what? So men, they are the pseudo people. They are false people. If you are female, remember this. If you are male, remember then that this means they won't live for their life. They will live their pseudo life for their mother and their father. These two things, it will be wind your confusion off. Next, you will be able to see this type of bodies or this type of two segregations where there is only in between there is just cell bodies and sides there is this cell nucleus. Okay, this segregations will be seen in a case of classical schwannoma, and you will be able to see one more bodies which are known as verrucate bodies. We will see one more bodies which is known as verrucate bodies in a case of schwannoma. Good guys. Next, if you are able to see this type of two things, this chicken wire calcification and this type of fried egg appearance. Both of them, they are classically seen in a case of oligodendroglioma. They are classically seen in a case of oligodendroglioma. Fine. Next, we are moving ahead to this hematology section. There is this three parts in hematology: anemia, leukemias, and lymphomas. Okay, if we are done with it, almost we are done. Okay, then anemia, we know the most common type of anemia. It is this iron deficiency anemia or this nutritional anemia. Usually, they will describe there is a female with features of fatigue and unable to do walk. Okay, now she's complaints of shortness of breath. Previously, she used to climb 4 stairs without having any difficulties. Now she's having difficulty on uphill. So you did a peripheral smear examination. You will able to see this type of cells which is known as pencil cells. They will ask you where you will see these pencil cells. Then your answer should be what? Then your answer should be it is what it is seen in a case of microcytic anemia, especially this iron deficiency anemia. Iron deficiency anemia. Bas. फिर उसके बाद आगे बढ़ते हैं. There are few more microcytic anemia. One is the sickle cell anemia. The sickle cell anemia happens because of glutamate goes. Okay, glutamate goes and valine welcomes. Valine welcomes. Okay, glutamate is being replaced by this valine at this beta 6th position. So the RBC will become this shape which is known as sickle shape. So it is the sickle cell anemia, and this sickle shaped RBCs, it won't stay like this. It won't stay like a normal us. It will be like a marriage child. Like if you see in a marriage, right? It means that there will be small childs. They will be roaming around. There will be no reason why they are roaming. Likewise, this sickle cell RBCs, they will just roam around, and when they see the small arteries and small capillaries, they will join and they will occlude the vessel. So it will causes what? It will causes this dactylitis. They will cause inflammation because on the fingers, because it causes obstruction over it. And next, it will go and occlude the spleen. 𝗵𝗵𝗀𝗀 spleen. Okay, what he did? Nothing, right? So it will go and occlude the blood supply to the spleen, and it can cause orthosplenectomy. Okay, बस इतना याद रखो. And at X-ray we will able to see there is appearance which is known as hair on appearance and fish mouth vertebra. And usually we know the most common cause of osteomyelitis. हम पढ़ेंगे. It is what it is this Staph aureus. Whereas in a case of sickle cell anemia, right? It is what it is this salmonella. It is this salmonella. फिर उसके बाद they will ask you how will you differentiate this iron deficiency anemia from anemia of chronic disease. ठीक है, याद रखो anemia of chronic disease आपके पास सब कुछ है, लेकिन आप सबको बोल रहे हैं मेरे पास कुछ भी नहीं है. ठीक है, जो जैसे होते हैं ना कि like there will be a guy every in their group in their class, एक पूरी रात भर पढ़ती है, लेकिन अगर पूछोगी तो कितना पढ़ा है, then what they will tell, no मैंने तो कुछ नहीं पढ़ा, बुक भी नहीं छुआ हूँ, like I never touched the book, like but they will top in the examination. Likewise this anemia of chronic disease, they have this iron, they don't need any hunger. Okay, they won't need any hunger. So if you see there is this, they studied, so their serum ferritin, their reserve will be more. Okay, so they don't be having any binding, उनका इच्छा ही नहीं पड़ेगा, मतलब they won't be having this appetite for study more. So their transporting saturated and binding capacity will be decreased. Okay, whereas their hepcidin will be increased because there is some chronic disease going on. So because of this chronic disease, this hepcidin will be increased. But just remember one thing which is same in the case of iron deficiency anemia, in anemia of chronic disease, both percentage saturation will be decreased. Percentage saturation will be decreased. Okay, क्योंकि इतना गलती करोगे तो means you will get less percentage, like instead of getting 95 you will get 92, right? So that is what. So there will be decrease in percentage. Okay, whereas in a case of iron deficiency anemia there will be decreased ferritin. So because of that you want to read, so there will be increased transferrin and increased PIBC and there will be a decreased hepcidin. There is no inflammation. तो उसके बाद आगे बढ़ते हैं. Okay, then the master regulator of iron metabolism क्या है? Hepcidin. Then about IDA, it is also associated with the syndrome which is known as Plummer-Vinson syndrome. And there is a features of this koilonychia, there is a features of this esophageal webs. All of them it is related to this Plummer-Vinson syndrome. Next thalassemia में क्या देखेंगे हम? Target cells देखेंगे. There are two types of thalassemia, alpha, beta. Alpha due to this chromosome 16 deletion, whereas beta it is due to this chromosome 11 mutation. ठीक है? And in the case of thalassemia, remember it is thalassemia. There is thalassemia. अगर thalassemia है तो क्या है? There will be a less Menzer index, so lesser than 13. In the case of thalassemia, there will be a less than 13 of Menzer index. Then there will be a thing which is known as paroxysmal nocturnal hematuria. It is because of this absence of CD55, 59. So the same P का उल्टा करो, it will be 9. So if you make P in a vice versa, it is the 9. So remember it is CD55 and 59. Okay, 55 and 59, and it is due to this defect in this Pedia. Okay, and this if there is loss of this central pillar, usually देखो इसके अंदर जो बीच में central pillar है, अगर if there is any loss of central pillar, we'll call them as क्या? Spirocytes. उसको क्या बुलाएंगे? Spirocytes. It is what it is this MCV by, like that is this Menzer index will divide this MCV by this total RBCs. Then hereditary spirocytosis, one condition which shows the spirocytes. The most common one it is this ankyrin, and the most specific one it is the spectrin. And here there will be increased osmotic fragility. And this spirocytes can also be seen, or the most common cause of the spirocytes क्या? It is this autoimmune hemolytic anemia. And there are two types of autoimmune hemolytic anemia. One is warm, another one is the cold. Okay, G for garam, G for warm. So IgG will be used in the case of warm, garam wala. Okay, and then this IgG1 will be involved in a case of two conditions, which is this Evans syndrome and CLL. Evans syndrome and CLL will be seen in a case of warm autoimmune hemolytic anemia. So warm matlab garam, so it is IgG. Whereas cold autoimmune hemolytic anemia, it classically involves IgM, and it includes this mycoplasma and malignancy and other infections. Next, our classical yesterday also we studied, right? This is this vitamin B12 deficiency causing this megaloblastic anemia. Okay, the organism which is this Diphyllobothrium latum, it can also lead to this decreased absorption of this vitamin B12 and can cause this megaloblastic anemia. Okay, itna yaad rakho. And in a case of megaloblastic anemia, you will be able to see this classical hypersegmented. It is not multinucleated, it is this hypersegmented neutrophils. फिर उसके बाद usual से बड़ा वाला, it is known as macroovulocytes, and there will be one more bodies which is known as Howell-Jollis bodies. Howell-Jollis bodies. We know vitamin B12 is helpful in DNA formation. So in a case of vitamin B12 deficiency, there will be a improper DNA formation which is known as Howell-Jollis bodies. और हम डायग्नोस करने के लिए हम क्या क्या देखेंगे, विल यूज MMC level and homocysteine levels. Both of them will be increased in a case of vitamin B12 deficiency. फिर उसके बाद आते हैं G6PD deficiency. You know G6PD, it is a part of HMP shunt. ठीक है, and if there is a history of anti-malarial or 𝗵𝗵𝗶𝘀 consumptions, there will be increased level of, there will be what? There will be this increased level of this free radicals, and it will lead to this type of bodies which is known as Heinz bodies. And on peripheral smear, you will be able to see this type of cells. They are known as what? Bite cell. फिर उसके बाद the two more topics, leukemia and lymphoma. Leukemia means जब तक blood का tumor blood में रहेगा, इसको बोलेंगे leukemia. If the blood tumor, if it is spreading to this vital organs or to the organs, then we'll call them as lymphoma. Okay. First one, it is what? It is all. ठीक है, सबको क्या पसंद है? सबको बच्चा पसंद है. ठीक है, so means like our बच्चा पसंद है और बचपन पसंद है. Okay, so everyone they like the children's, right? They like the children's, like so the most common type of leukemia in children, it is what? It is this ALL. Next, if you're able to see this ALL, they will ask you which of the following is the good prognosis. If you know this good prognosis, you can tell which is worst or this poor prognosis. The good prognosis, it is what? It is the hyperdiploidy or female and translocation 1221. So here you will be able to see these are this lymphocytes which is uniform. Okay, which is uniform. Okay, remember. So most common type of leukemia in children क्या ALL. Okay, it is ALL. Okay, फिर उसके बाद AML. Okay, AML में there are different types of leukemias. There are different types of classifications. तो आपको याद रखना what are the translocations. See AML M2 it is known as what? It is be causing this thing which is known as scleroma, and it will be having this translocation of translocation 821. Remember, it is 8 and 21. It is 8 and 21. Whereas M3, which is known as what? PML RARA fusion. PML RARA fusion, which will be having these rods. They are known as what? They are known as OR rod. And what is the name of the cells which is having these OR rods? They are known as Fagot cells. So Fagot cells and OR rods will be seen in a case of AML M3, and it is due to the translocation of 1517 of this PML RARA fusion. Okay, and in the case of M4, multiple 4 into 4, it is what? It is inversion 16 involved. Okay, so AML, it is this one. So usually in the case of ALL, it will be the children, they will give this history and they will give this peripheral smear, they will ask you which of the following is a good prognosis or identify the diagnosis. Whereas in the case of AML, they will ask you, you will able to see these OR rods in this picture in a child who is presenting with features of bone pain and anemia. Okay, and now what is the translocation you will see? So the translocation you will see in the case of AML M3 क्या? It is what? It is translocation 1517, which is this PML RARA fusion. It is the PML RARA fusion. फिर इसके बाद आगे बढ़ते हैं. Next one, it is the CLL. CLL mostly it is seen in a case of elderly patients, and remember CLL will be positive for 5 and 23. CLL will be positive for 5 and 23 positive, and here there will be two features. There will be this massive splenomegaly and along with this lymph node involvement. So how will you differentiate the CLL and CML? It is the lymph node. In the case of CLL, there will be lymph node involvement, whereas in the case of CML, there will be no lymph node involvement. Okay, and there will be this syndrome which is known as Richter syndrome. Richter syndrome, it is what? We will see this garden party appearance in the case of CML. Okay, in the case of CML, you will see this garden party appearance. Next, in the case of CLL, what you will do? What you will see? There will be this syndrome which is known as CLL. Sometimes this CLL will become what? Very small cells, and in it, then it can transform into DLBCL. It is known as Richter's transformation. And if the CLL it is being associated with this autoimmune hemolytic anemia, it is known as Evans syndrome. It is known as क्या? It is known as Evans syndrome. Okay, and we know in the case of CLL there will be a component which is absent, which is known as what? Which is known as Vimentin. Vimentin. So we know this Vimentin, it is helpful for the integrity of the cells. Okay, अगर आप एक सेल को लेकर स्लाइड के ऊपर रखोगे, it will be integral like this. लेकिन because of this Vimentin, it will be like this. So when you put this cover slip, this cell will be smudged. ठीक है, ये टूट जाएगा. तो this टूटा हुआ सेल इसको बोलते हैं smudge cell. Smudge cell. Okay. Then in CML, you will able to see. I told you will able to see this massive splenomegaly and lymph node will be absent. And here this catch point, which is this T92, translocation 922, which is this BCR-ABL fusion. Okay, Philadelphia chromosome. Okay, and there will be increased all the lineages which causes this garden party appearance, and there is this one more tumor which is happening in the plasma cells, which is this multiple myeloma. Usually there is this old age patient with sclerotic heart. There will be this lytic lesions on the skull and on the vertebra, and there is a features of this anemia. Okay, and there will be features of this crab. Okay, there will be this hypercalcemia, there will be this renal features, and there will be this anemia. And in blood, you will be able to see there is this immunoglobulin deposition leading to this type of cells. There will be this grape cell, there will be this moat cell, okay, moat cell, and intranuclear Dutcher body and intracytoplasmic Russell body. So Dutcher body, Russell body, moat cells. All of this thing will be seen in a case of multiple myeloma. Okay, and multiple myeloma, you will see this translocation of translocation 1114. Translocation 1114. Here, okay. Then, if you are able to see this type of cerebriform cell will be seen in a case of T cell type of non-Hodgkin's lymphoma, which is what? Which is this Sézary syndrome. They are known as Sézary cells will be seen in a case of Sézary syndrome. Okay, there you will be able to see this substance which is known as Munro's microsubstance. Okay, I will ask in dermatology. Okay, Sézary syndrome. Uske baad we'll come on to this final part, and there is few extra age left. Okay, in final part we'll see this Hodgkin's lymphoma. Remember, Hodgkin's lymphoma, there are two types: classical and non-classical. Classical means, for example, what is the classical things seen during FMG preparation? Depression. Okay, depression, demotivation, lot of problems and only problems. Okay, these are the classical features of an FMG aspirants. Okay, there is some atypical patients will be there, right? Like there will be few people will be jolly during FMG preparation, jolly during or happy during these FMG results because they didn't pass, they have 6 more months, and they are what? They are this atypical person. So if you put our efforts, will be into this typical line and they will come out as pass person. Okay, that is what. So in the case of Hodgkin's lymphoma, it will be classically, it will be positive for the CD15 and CD13. Okay, CD15 and CD30. Okay, and there are different types. There are nodular sclerosis, mixed cellularity, lymphocytic leach, and lymphocytic. All of them, they will be having this classical of CD15, फिर उसका 2 time. It is 15 plus 15, it is CD30. So 15 and 30 will be positive in a case of classical type of RSL, which is this classical Hodgkin's lymphoma. Okay, here the most specific one, it is the OX5. And non-classical, it is the nodular lymphocytic predominant. Here there will be this CD15 and 30. Okay, both of them it will be negative in nature. Our atypical guys. Okay, so अगर atypical है तो उनका तो कुछ ना कुछ चाहिए ना, तो they'll be having this they'll be having this biased things like all of enjoyment stuffs like sutta, daru, ठीक है ना, so ganja. So like if they have these atypical things in their life, so it is what it is the atypical. It is the CD20 and 40. It is not other part of life. If it is having it, it's okay, but during preparation you should be oriented. ठीक है ना, तुम्हें लड़ना है तो लड़ने के लिए क्या चाहिए? तुम्हें एनर्जी चाहिए, और तुम्हें क्या चाहिए? उसके लिए जिद चाहिए. So just keep on fighting for it with these typical features of this depression, problems, everything, but your efforts, your consistent efforts, if you are doing, then you will come out of this FMG examination. That is my point of view, and that is the thing which actually happens. Okay, so in a case of non-classical, I told they will go for even movies. So movies क्या मिलेगा? Movies में popcorn मिलेगा. So in a case of non-classical, we will be able to see this popcorn cells. Okay. Next, in the case of non-Hodgkin's lymphoma, there are different types. Here you need to know about this translocation. So remember, mantle cell, it will be positive for this vitamin D1. Okay. Whereas this follicular, it will be positive for this positive for this BCL2. Okay. So then you want to know about their translocation. So translocations के लिए याद रखो 11, 14 और 18 means 11, 14 and 18. So first mantle के लिए पहले 2 दे देते हैं. ठीक है. You give first two for this mantle. So it is 11, 14. फिर बीच में जो भी बचा, it is what it is 14. FF follicular. So 14 follicular, it is what it is 14 and 18 will be seen in a case of follicular lymphoma. फिर margin में क्या क्या है? Margin में it is 11 and 18. अगर margin में 11 and 18 है तो the marginal lymphoma will be having this translocation of 11, 18. ठीक है, बस इतना याद रखो. And this marginal one, it will be positive, negative for both CD5 and CD23. फिर उसके बाद आते हैं, there will be this African child who is presenting with this lymphadenopathy and this classical 𝗧𝗵𝗶𝗀𝗀. Where you will see this 𝗧𝗵𝗶𝗀𝗀 guys? 𝗧𝗵𝗶𝗀𝗀 appearance in lymph node biopsy. कौन से lymphoma देखोगे? Burkitt's. So this what it is, this Burkitt's lymphoma. Okay, and we know this Burkitt's lymphoma, it will be having this association with this Epstein-Barr virus, and B for B, the B को 8 बना दो. So it is this 814 translocation, and there will be this proliferation index which is known as 𝗃𝗂𝘁𝗲, it is 100%, and it will be showing this starry sky, whereas this sky, the sky is all the FMGs, whereas the stars are you, like macrophages who is fighting for your life and fighting for this FMG life. So the stars are these macrophages, whereas this sky, it is what it is, this tumor cells. Okay, it is the tumor cells. Next, if you are able to see this hairy projections into a cells, it is what it is, this hairy cell leukemia, or हमें पढ़े it is what it is, positive for this BRAF cell, and we know annexin 5 we studied in apoptosis, whereas annexin A1 it will be positive for this hairy cell leukemia. Thus these are the main contents you have to remember about this lymphoma. फिर थोड़ा extra एज देखते हैं, बस उसके बाद break ले लेते हैं. So if you are able to see this type of dye, okay, triphenyl tetrazolium chloride, you will see to diagnose this MI. Okay, अगर means this will go and bind to this LDH. It will bind to this LDH because usually हमने पढ़ा कि in a case of cellular injury there will be reversible, irreversible. In a case of reversible cell injury there will be no damage to the cell membrane. लेकिन जब irreversible cell injury होगा तब cell membrane टूटेगा. अगर cell membrane टूटेगा तो उसका content बाहर आएगा. One of the content is what is the enzymes, which is this lactate dehydrogenase LDH. So this dye will go and combine with this LDH, and when they will be combining, they will be cushy. When they will be happy, they will show up the color, that is the white color. Okay. Next, about this blood test, if you see, there will be in a case of inflammation, there will be the increase in cytochrome C and annexin 5. Cytochrome C and annexin 5. And about this programmed cell death, it is what? It can be caspase dependent and caspase independent. In a case of caspase dependent, we know it is the apoptosis. And if it is caspase dependent but it is having inflammation, it is what it is, this pyroptosis, which is having this C11 involvement. Okay, whereas in the case of apoptosis, there will be this inflammation will be absent and it will be having this all caspases, caspase 3, 4, 7, 8, 9 and 10. Okay, caspase 3, 4, 7, 8, 9 and 10. Fine. And about deposits, you have to know, if it is lipofuscin, it is the lipid, it is what? It is a wear and tear pigment, and for staining lipids we can use this pigment or stain which is the oil red O. Hemosiderin is the iron containing pigment, we will use this blue stain which is this Pearl's Prussian blue. Copper will use two stains which is the rhodamine and rubionic acid. Calcium will use this two stain which is this vancomycin and alizarin redness. For melanin we will use this mesenphentana, whereas meson trichrome will use for healing or during this granuloma formations. Okay. Then for calcium, we will see two things. Calcium, there will be dystrophic calcification and metastatic calcification. Remember, dystrophic calcifications happens in dying tissue. So here it happens in dying tissue. The calcium will be normal here. An example of this, it is this our favorite 𝗵𝗵 bodies. Okay. Papillary carcinoma thyroid, serous cyst adenoma of ovary, and meningioma. Okay. Then metastatic calcification, it is usually seen in a case of normal tissue. Here why it is deposited into the normal tissue? Because there will be increased calcium, and it is seen in a case of RCC, milk alkali syndrome, and multiple myeloma. So remember this multiple myeloma, one of the criteria it is hypercalcemia. Okay. Then uske baad Turner syndrome, there will be this 45XO and there will be the features of lymphadenoma. Okay, lymphedema, there will be swelling around the neck. फिर उसके बाद Down syndrome. In the case of Down syndrome, there will be this. It happens because of this meiotic non-disjunction. It happens because of this meiotic non-disjunction. Yeah. For calcium, we'll use this most common stain, which is this vancomycin stain. And next, about this Robertsonian translocation, it will happen in most old age patients. There will be this Robertsonian translocation. It is the translocation 14 and 21. And the most common type of leukemia in Down syndrome, it's also ALL, and it is more specific if they ask, it is the AML-M7. Okay, more specific it is AML-M7, and most common it is the ALL. Okay, and Klinefelter, the chromosome number is 47XXY. Okay, which will be having this mental retardation, and heart you will be able to see this mitral valve prolapse, and there will be this increased risk of leukemia, and there will be enlargement of breast in males, which is known as gynecomastia, and there will be presence of Barr bodies in males. Okay, remember. And evaluation you will able to see, because of this there will be decreased testosterone and increased LH and FSH. बस इतना याद रखो. And few trinucleated repeat disorders, Fragile X syndrome, it is the most common one, it is the CGG repeats, whereas Friedreich's ataxia, though A hai, so it is GAA. Myotonic dystrophy, remember it is this CTG. CTG will be seen in the case of myotonic dystrophy. Or Huntington's chorea, agar hunter hai, so he need a cage. Okay, he need a cage. So it is what? It is the CAG repeats. The same for spinocerebellar ataxia. So remember it is Friedreich's ataxia, it is GAA. Whereas in a case of spinocerebellar ataxia, it is CAG. Okay. Then Kennedy's disease, it is the CAG repeats. Fine. Then about few more receptors. This TLR receptors means T cell receptors, it is toll-like receptors, it is for the bacteria. lecithin, lecithin is present in the fungal walls, it is for the fungus. Rig-like, it is for this virus. Rig-like, it is for the virus. And node-like receptors, it is for the NFR and it is for this necrotic cells. And in the case of inflammatory bowel disease like Crohn's disease, it will be having a mutations for this node 2. It will be having this mutation for this node 2. Next about this bleeding disorders, just remember, in the case of hemolytic uremic syndrome, there will be hemolysis, uremia and syndromes. Like why there is hemolysis? There is this clumping, there is formation of clot and RBC will be trapped. So this lead to this breakdown of the RBC. So there will be a hemolysis. So because this there will be formation of clot, there will be what? There will be usage of the platelet leading to thrombocytopenia and they will come and affect the renal. So it is known as hemolytic uremic syndrome. Because of this there will be increased uremia levels. Okay. And this Bernard-Solier syndrome, remember it is GP1B. Bernard-Solier syndrome पहले आता है तो GP1B or 9 like it is what? It is the Bernard-Solier syndrome, whereas GP2B it is what? It is the Glanzmann thrombasthenia. It is the Glanzmann thrombasthenia. And hemophilia, we studied like it is a X-linked recessive disorders. Hemophilia A, it is 8. B, it is because of the factor 9 deficiency. C, it is because of the 11. So remember, it is 8, 9, not 10, it is the 11. So 8, 10, 11. 8, 10, 11. 8, sorry, it is not 10, it is 8, 9, 11. Okay. Then if you see this von Willebrand deficiency, it will lead to this two things. It will lead to this platelet adhesion defect. Along with this, it also decreases the factor 8. It decreases the factor 8. So there will be BT also will be involved, means bleeding time will be more and APTT also will be more. Fine. And there are few immunodeficiency diseases. So there is one thing, it is VAS. VAS means a past. So then you will tell in past, you will tell boy. Okay. So when you see your X, you will tell boy. So it is bi. Okay. So it is what? It is the bleeding, infections and eczema. So it mostly the child with bleeding, infection, eczema. The next one is the Dijkstra syndrome, will be having this mnemonic of catch. There will be this cleft lip or cleft palate and cardiac anomalies, abnormal faces, there will be this thymus anomalies and it will be involving this 22nd chromosome. And SCED we know it is due to the deficiency of adenosine deaminase. Okay? Then the final one, it is this blood bank. अगर आपको blood bank में याद रखना है, so remember PRBC it will store as 2 to 6 degrees and usually it is stored up to a day of 42 days. So हम लेकिन mostly हम 35 days के लिए रखते हैं, okay, because we have the availability of this only. Then platelets usually will keep in room temperature and with constant agitation, okay, and will keep at room temperature of 20 to 25 degree Celsius. तो अगर हम room temperature में रखेंगे तो इसका validity बहुत कम होगा. तो it is what it is for just 5 days we can keep them. As this fresh frozen plasma and cryoprecipitate हम उसको deep freeze करेंगे at 18 degree temperature तो हम 1 साल तक उसको रख सकते हैं. But remember in question they will ask you got a fresh frozen plasma, okay, which is stored for 8 months, okay, stored for 8 months to your patient. Now the patient discharged before telling you. Now you have this thawed fresh frozen plasma, means previously it was freezed. Now what you are having, it is not freezed one, it is being converted into the normal temperature. Now they will ask you, as a intern, what you will do? You will bring back to the blood bank and keep it for 2 more months and use it later, or you will discard it. What will be your answer? You may think that there is 4 more months left, right? But no. Once this deep freezed plasma or this cryoprecipitate, if they thawed, means if they brought to the normal temperature, we cannot keep them back. Okay, so if it is thawed, then we need to dispose them for sure. Okay, fine. And usually this PRBCs will be previously stored in this ACD, which was for just 21 days. We added this energy particle, which is this adenosine. So now it can withstand for 35 days. We have more improved one where we can store for even 42 days, which is this 𝗧𝗵, which is having this osmotic maintenance. Okay, that's it guys. That's it for the pathology part.